Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I would like to welcome our audience and speakers to today's events. I'm Dr. Brian Kaufman, the co-founder, Executive Vice President, and Chief Medical Officer of the nonprofit CLL Society. And today we are joined by Dr. Veronica Dioverti, Assistant Professor of Transplant and Oncology in the Division of Infectious Disease at Johns Hopkins University, and by Robin Brumble, Director of Scientific Affairs and Research at CLL Society. It is now my pleasure to welcome Dr. Veronica Dioverti. Dr. Dioverti?
Hello, I'm happy to be here today to talk about preventing COVID-19 and some other respiratory viruses in immunocompromised. My name is Veronica Dioverti. I'm part of the Transplant and Oncology Infectious Diseases team at Johns Hopkins University. Some of our learning objectives today include reinforcing the need for ongoing infection control precautions, early testing and early treatment for COVID-19 and also other viruses, review the latest vaccine recommendations for COVID and other viruses, and we're going to mention some of the relevant clinical trials related to COVID-19 for which you may qualify. So where are we now with COVID-19? So as we all know, COVID-19 virus or SARS-CoV-2 is constantly changing and new variants emerge. However, some of those older variants actually may disappear. Some of them actually may persist. It really depends on the changes, whether they were beneficial to the virus or not. But good news is that the symptoms actually remain pretty much the same. We're not seeing that the virus are becoming more contagious than other, although we have seen some in the past, and we're not really seeing a significant increase in severity. So some of those symptoms include those that are related and very similar to other respiratory viruses. So we call upper respiratory virus infection. And so some of those include fever, chills, coughing, most of the time a dry cough. You can experience trouble breathing, and sometimes your oxygen levels can go down. You could also have sore throat, headaches, and we know the hallmark of COVID-19 is loss of taste or smell, which is not a hallmark for other viruses. We have seen that a lot of our immunocompromised patients do come in with stomach flu symptoms, such as nausea, vomiting, and sometimes very significant diarrhea. The graph to the right side shows COVID deaths from all the way back to 2020 to now. And as you can see, we are doing significantly better. And a lot of this has to do with vaccination, but we can still do better, and we still see deaths from COVID-19. Now, in our immunocompromised patients, and keep in mind that people with CLL, SLL are immunocompromised regardless of whether you have started your chemo treatment or not. And so even without treatment, you have enough disturbances to your defense mechanism or your immune system to put you in the category of an immunocompromised patients. There have been tons of studies looking and comparing COVID-19 outcomes in those with normal immune systems, so immunocompetent, to those that are immunocompromised or that have lower impaired immune system. And we see that among those that are unvaccinated, people with immunocompromising condition had at least 1.26 times higher odds of getting admitted to ICU and 1.34 in hospital deaths than those without immunocompromising condition. When we also talk about vaccinated patients, we see the same difference. And so those that are immunocompromised have 1.4 times ICU admission rates and 1.8 in hospital death than those that are not immunocompromised. Now, if we want to have a fair comparison and we look only at immunocompromised patients and compare those that are vaccinated to those that are unvaccinated, that difference doesn't stand out. So the difference is not really significant. And probably the most likely reason to that is that we know that immunocompromised patients tend to not respond to vaccine very well. And CLL is one of the largest category of patients that tend to respond to vaccine much lower than others. So because of that, we do need additional protective measures for our immunocompromised patients. And some of them include being up to date with vaccines, although we do know that you'll respond lower than others that don't have compromising conditions. We still want to see that you do get vaccinated. The more vaccines you get, the higher the response rates, the further out you are from your treatment at the time of vaccination, the higher the chances that you'll respond to vaccines. It's very important to have that conversation with your provider in terms of timing of vaccination as it relates to your chemotherapy. We know that some of those, or immunotherapy, we know that some chemotherapy and some immunotherapy may have a higher impact of poor vaccine responses than others. We did have monoclonal antibodies for prevention. We don't have any currently, and we'll review this a little later, but that was a great added layer of protection to vaccines. But more importantly, since we don't have any other measures right now in terms of monoclonal antibodies, it's early testing and early treatment. This little graph will go over. If we look at the top part of the figure, you'll see the words PrEP and PEP. PrEP essentially means pre-exposure prophylaxis, meaning that in those patients that we know are not going to respond to vaccine very well, we can give injections of what we call monoclonal antibodies. And those are essentially pre-made synthetic antibodies that we give you to keep you protected so that we don't have to rely on your immune system ability to respond to vaccination. PEP means post-exposure prophylaxis. We did have a monoclonal antibody a few years ago to do this. It essentially means that once we know that you're exposed to COVID-19, we would give you a monoclonal antibody to keep you from becoming infected and sick. Now, we talked about vaccination, and we'll review vaccination schedule in a little bit. Early treatment and early testing is very, very important. And you'll hear me say this over and over and over again during this presentation. But we have a number of different antiviral therapies and other things that we can do to treat COVID-19 and keep you from getting sick. When we're talking about severe infections, we're really talking about getting you to the hospital and treating you there. And we're not going to discuss that treatment, but also very important public health measures. And vaccinating those around you that care for you is actually one of the most important measures to keep you safe. So wearing masks, although the mask mandate is no longer in place, it's still very important for you to wear masks. And there are different kinds of masks. For the vast majority of us and our patients will use simple surgical masks. The next one better than surgical masks are the KN95. And then the best of them is the N95. However, that's a little difficult to wear. And so the vast majority of our patients will wear KN95 masks. Very important to keep your hands clean all the time. If you're using public restrooms, you want to make sure that you're washing your hands or using alcohol hand sanitizers. And you want to make sure to avoid crowded areas, particularly during this time of the year that we can't really do anything outdoors anymore, at least not where I am. Because it's getting too cold. But that's very, very important. Keeping distance from others that you don't know their vaccination status or you don't know if they're having symptoms. And now with the holidays coming up, it's also very important that if you're gonna spend some time with family members, to please teach them how to keep you safe. Make sure that they're vaccinated. And I know a lot of people don't want to get vaccinated. So if you have family members that are not vaccinated, ask them not to visit if they are experiencing any symptoms consistent with respiratory viral infections. And I put this down there. You can actually get free home COVID test kits through the CDC website. There's the link and phone number. But if you just Google the CDC website, you can actually order them too. I mean, it's very important to keep test kits at home. So we have had a number of different COVID vaccines coming through the years. We had the original one that was directed against the original strain that was withdrawn earlier this year. After last year, about a year ago or a little over a year ago, we had the bivalent vaccine coming up, which included the earlier variants and some of the new ones. That was withdrawn in September of this year after we got the third version of the COVID-19 vaccine, which is the updated COVID-19 vaccines. And essentially, anybody who's 6 months and older should get vaccinated and should get at least one dose of the COVID-19 updated vaccine. But the number of vaccines you'll get, it really depends on how many vaccines you've had in the past. So if you've never been vaccinated before for the Pfizer, which is a messenger RNA vaccine, a newer kind of vaccine that's actually been around for many, many years. So the primary series would consist of 3 different doses. The first dose, 3 weeks later, a second dose, and 4 weeks after the second dose, the third dose for those that are aged 4 years or older. For the Moderna vaccine, which is the other messenger RNA vaccine, the same applies. So it's the first dose, 4 weeks later, a second dose, and 4 weeks after the second, we get the third. For Novavax vaccine, it's actually 2 doses separated by a week. Now, it gets a teeny bit more complicated if you've been previously vaccinated. So if you've got one previous vaccine, then you'll get doses number 2 and 3, as we reviewed on the previous slide. If you've got 2 previous vaccines, you would get the third. All this with the updated one, which is the only one around right now. If you've gotten 3 or more previous vaccines, and some of my patients have gotten 5 or more, you would still need to get 1 dose of any of the updated vaccines at least 8 weeks after your last dose. This is for the Pfizer vaccine, but again, very, very similar recommendations for the Moderna vaccine. So if you've got 1 previous dose, you get second and third. If you've gotten 2 previous doses of the vaccine, you get the third. And if you've had 3 or more, at least 1 updated. And I say at least because CDC has left a little bit of room to get even a second dose if needed to in some of our immunocompromised patients, but that's at the discretion of your provider. So I encourage you to have that conversation with your doctor. And then for the Novavax, if you've got 1 or more doses, then it's always 1 more dose of the updated any kind of vaccine. Now, we talked about having a number of options for treatment, and it's actually one of the viruses to which we have, outside of HIV and others, we have a lot of antiviral options. However, each one of them has a little drawback. So the first one that we use very commonly is called remdesivir. It was approved in October 2020. However, this is intravenous only. So for you to get this particular treatment, you would have to either get admitted or go to an infusion center. We are very lucky that we do have an infusion center. So usually what we do is bring our patients on a daily basis to give them the dose of the day. The courses can be as short as 3 days, as long as 10 or even more days, but that depends also on your provider's judgment, but at least 3 days. The next step is called nirmatrelvir ritonavir. Everybody knows this one by the name of Paxlovid. It was approved earlier this year. This one's oral only. But very, very important to remember that this particular medication, although it's a great antiviral, it has a lot of interactions with many other the medications that you usually take, including blood thinners, some immunotherapy, some chemotherapy. So it's very important that if you were to take this particular medication, it has to be prescribed by a provider that has reviewed the list of medications that you take that needs to be up to date and make sure that there's no contraindication. For some of the medications that you take, we can hold it for a few days or even decrease the dosing, but it's very, very important that we do so when we're using this medication because it can have serious consequences. There's a third antiviral called molnupiravir. This is oral only, but it's much lower efficacious than the other two. And so it tends to be a last option. There's also other types of intravenous treatment that we call passive immunotherapy, essentially meaning that we're boosting your immune system with antibodies against COVID. You might have heard about convalescent plasma, which is essentially a transfusions of highly concentrated COVID-19 antibodies. And some of you may have heard about intravenous immunoglobulin or IVIG. There's also a subcutaneous version of it that we sometimes use in patients that are very immunocompromised. So this is also an option. This is not COVID-19 only antibodies. It has antibodies against other viruses, but it seems to also provide some benefits in treatment of COVID-19. A syndrome that's catching our attention recently, some of our immunocompromised patients can have persistently positive tests against COVID-19, particularly the home COVID antigen test. And it's a syndrome whereby you test persistently positive for COVID and have intermittent symptoms. And sometimes those symptoms can include fever, coughing, trouble breathing, low oxygen. We're beginning to call this syndrome protracted COVID-19, and we're learning more and more about it. It's very, very different from long COVID, where people can have different kinds of symptoms, but with negative COVID tests. If you think you fall into this category, you should talk to your provider about it because you may need more treatment. There are very few clinical trials ongoing right now. For monoclonal antibodies, there are 3 companies that are working on monoclonal antibodies for prevention. AstraZeneca, I think, just finished the recruitment. Regeneron will start enrollment soon. And then Invivyd is also working on an antibody. There was another trial from Pfizer with Paxlovid for immunocompromised, but that also finished recruiting. For up-to-date information, I would encourage you to visit the CLL Society website. Has great information about clinical trials that you may be able to get into. Other viruses that we're going to talk about today, we're seeing a lot of influenza around. We do have great vaccines for that too. They are updated on a yearly basis, and you should get this vaccine yearly. They are all quadrivalent vaccines, and we do have a high dose version of vaccine, but that's only been approved for patients over 65 years of age. However, you could discuss with your provider about getting this particular vaccine, but you may either need to go for prior authorization with your insurance or pay out of pocket. So I would encourage you to talk to your providers about this because they can help you. Testing, as I said before, early testing is very important. It's very difficult to distinguish influenza from COVID-19 based off on symptoms. And so it's very important to get tested. And we do have good treatment for influenza, which is oseltamivir, or commonly known as Tamiflu, that also should be started as soon as possible. Another virus that's floating around, you might have heard about, respiratory syncytial virus, or RSV for short. We have 2 vaccines that just came out this year. They're from GSK and Pfizer. These are single-dose vaccines. It's been approved for adults over 60 years or older, also for kids and pregnant women, but we're not going to talk about that today. But it's only for 60 years and older. So if this is something that you would want to consider, again, it would have to be a conversation with your provider, and you may either need to pay out of pocket or go through prior authorization with your insurance. Again, very important to get tested for this. If you have symptoms, we cannot distinguish symptoms from COVID, influenza, and RSV. So we usually recommend testing for all 3 of them. We also do have treatment for this. It's an oral antiviral called ribavirin. that we offer for patients that are highly immunocompromised to decrease progression to pneumonia. So, in summary, it's very important to keep in mind that if you are having any respiratory symptoms whatsoever, you need to get tested immediately. That is the best way to prevent you from progressing to severe infection. You can start with a COVID-19 home antigen test. If that is positive, call your provider, get treated right away. Don't wait even 24 hours because that would be enough to allow COVID-19 to progress to severe infection. If the home antigen test is negative, I would encourage you to get a rapid COVID-19 influenza RSV test that can be done at any urgent care or even at your provider's office to see if you have any of those three viruses. And if you are positive for any of them, please get treated immediately. As I said before, we have 3 antiviral options for COVID-19. Each one has downsides. Paxlovid and remdesivir are the most efficacious. For influenza, we have Tamiflu, and for RSV, we have ribavirin. So it's very important to get tested early, treated early. Now, lastly, we do have a pneumococcal vaccine, better known as pneumonia shots by patients. This is actually not a virus. It's a bacteria called Streptococcus pneumoniae, which can cause severe pneumonia in immunocompromised patients. Now, I'm not going to go over how complicated the vaccine schedule is. We've had a number of different vaccines through the years, and so currently, we have 3 of them. Which one you get will depend largely on what you've gotten before and where you are with vaccination and treatment. So bring this up with your provider, review the vaccinations that you've had in the past, and they will tell you which one would be the best next to get. Remember that every single immunocompromised patients need to get the shot, regardless of where you are with your treatment. The influenza is a yearly vaccine. The RSV is age 60 or older. And then we have the COVID-19 vaccine that we reviewed timing and schedule for vaccination. And with that, I'm going to stop and welcome Mrs. Robin Brumble from CLL Society, which would be our next speaker. Thank you.
Hello, everyone. My name is Robin Brumble, and I'm going to review CLL Society's COVID-19 action plan with you today. The reason behind why CLL Society put together a COVID-19 action plan is because in early 2021, those in our community were reaching out to CLL Society after having either known exposure to COVID-19 or receiving a positive test result, and many weren't quite sure what to do. Since that time, we have made several updates to the action plan. And as we know, the only constant throughout the pandemic has been continual change as new data emerge and treatment recommendations are often updated. Since this document has been updated multiple times, the plan has been created based on the most recent recommendations. So please make sure you have the most recent version available to you by checking the dates of when each document was last updated. The COVID-19 action plan is comprised of several checklists that we highly recommend individuals fill out before COVID-19 impacts your home. If you have not already, we highly recommend that you spend some time reading through the directions and filling in the blanks as they apply to your unique situation. Then print out the completed checklist if you can, and keep your personalized plan in an accessible place so that you can easily refer back to the plan when you need to. I'm going to very briefly go through the different pieces of the plan and provide some screenshots. The first 2 pieces of the plan include reading through the detailed step-by-step directions and then filling out the corresponding checklists that is called Complete Prior to Exposure. The intent of these first 2 documents is to guide you through exactly what you need to do far in advance of getting COVID-19. Some advanced planning is highly recommended as time is of the essence in finding and obtaining COVID-19 treatments after an infection has been confirmed. And some have reported to us that if they waited to plan until they confirmed their infection, it has sometimes taken several days to figure out where they need to go, determine what locations have those COVID-19 therapies available, and then having to take additional time to make appointments to actually obtain those therapies. Some important things that these first two checklists will walk you through include looking up important phone numbers you will need to call ahead of time, keeping a suggested list of supplies readily available, as well as how and where to quickly obtain those COVID-19 therapies if needed. The next two checklists include what to do if you have known exposure to COVID-19 or a positive test result. These two documents will guide you through exactly when you should obtain a COVID-19 test after known exposure, how long to monitor for symptoms after exposure, and perhaps most importantly, how to adequately quarantine and isolate. If you aren't quite sure what steps you should take to try to keep from getting COVID-19 from someone else in your home who has already tested positive, please read through this checklist so you can be well informed and prepared. It is in fact possible not to become infected from someone you live with if everyone takes the appropriate infection control precautions as soon as infection is suspected, and especially after infection is confirmed. The next checklist I will be sharing with you is perhaps the most important. It tells you exactly what things to do after testing positive for COVID-19. This checklist reminds you of the steps to take early on, which again is key. One of which is to call your healthcare provider immediately to discuss any COVID-19 therapies that you are eligible for as soon as possible. It will also prompt you to keep a log of your vital signs and symptoms, what to remember to do should you need to seek emergency medical care, and steps to take to make sure your illness has run its course and you are no longer infectious, which can sometimes take quite a bit longer in those who are immunocompromised. You can find all of these checklists on our website at cllsociety.org. As you can see in the screenshot of our website, there is a COVID-19 title located near the top of our homepage on the menu bar. If you click on that from the homepage, it will then take you to our dedicated COVID-19 information page. Then in the middle of our COVID-19 information page, you will see an option that says COVID-19 Action Plan. After clicking on the action plan, you will be directed to the page where you will find all of the checklists that I have reviewed with you today. Please remember the COVID-19 action plan is there for you on our website whenever you need it, but we highly recommend you access it ahead of time before you are exposed or before you start to feel ill. Doing so will help you have a better peace of mind, knowing exactly who you plan to call, what supplies to have on hand, and what to do should you or someone else in your household become infected. After you complete your COVID-19 action plan, we suggest you keep your checklists in a folder, place them in an easily accessible place so that you can find them. It's also extremely important to discuss your plan with everyone in your household so that they too can know what to do and what to expect should anyone become infected. And please remember, if you do have known exposure, any symptoms, or if you have a positive test result, act fast. Even if you don't have symptoms yet, please call your healthcare provider right away because obtaining available COVID-19 therapies as soon as possible remains to be one of the very most important things you can do to achieve your best outcome. This is especially true for those with CLL and SLL. Thank you, keep learning, and please stay safe.
So seeing as this RSV came up, can you tell us a little bit more about the vaccine, whom you're recommending it for, and a little bit more about whether people should plan to get the vaccine or the reasons? Are there groups that shouldn't get the vaccine if you're immunocompromised? If you could help us with that, Dr. Dioverti.
Sure, and hi everyone. I hope everybody can hear me nice and clear. So the RSV vaccines are definitely newer to us, and they have not been studied in the immunocompromised population. So I'll start with that. And so there's still a lot of unknowns in terms of, whether we should be giving this vaccination to everyone and what the timing is. Of course, we do want to offer this vaccine to all of our immunocompromised patients. They're two different vaccines from two different companies. They're both good. They're both approved for individuals aged 60 or older. And so if you were to want to get this vaccine, if you're younger than that, then it'll have to go through your insurance or you'll just have to be out of pocket. But they're both recommended to anyone who's immunocompromised. RSV can cause very severe infections, can push in the hospital with pneumonia. As a result of that, you can get other kinds of pneumonia and other infections with other organisms. And so it's really important to do anything and everything you can to keep you from getting these infections.
And I would add that RSV is an infection that our young grandchildren can get. And a friend of mine has had his grandchildren in a hospital with RSV. It can be quite severe for the little ones. And of course, as the grandparents, if we're babysitting them, we can capture that. We can catch that infection from the kids. It was, I used to think of it mainly as a childhood infection, but now as a family doc. But now it seems like it's more common in the adult population too.
Indeed, and that's actually the story that we hear over and over again. My grandkid has the sniffles, a little while ago, and then our adult patients that are immunocompromised can suffer from it greatly too.
And you can fight with your insurance whether you're going to win or not, but you can fight with your insurance as an immunocompromised patient to get them to pay for the vaccine. I got the vaccine. I have to tell you that I got a pretty darn sore arm from that vaccine. And my wife was actually had a fever and malaise and stuff for a day or so, but I didn't get that. So it's not a nothing vaccine. I just to give you a warning, at least that N of 2 that I'm sharing there. There's something that I have several questions on, and I want you to spend a little extra time explaining this. I want you to explain the difference between the vaccinated and unvaccinated data, because if you don't look at it carefully, it looks like you're actually at a higher risk if you're vaccinated. But I think you were comparing the immune competent versus the immunocompetent. Could you explain that slide? And are you actually at higher risk if you're not vaccinated and you're immunocompromised?
So I want to make sure that we compare the right patient populations. And so I think for us to really compare patient populations, we have to look at those that have a healthy immune system, so immunocompetent, to those that have an abnormal immune system, what we call immunocompromised. And as I said before, patients with CLL, even prior to getting any kind of treatment, are immunocompromised. We know that from other studies, and there are a lot of different changes here, white cells, which are the ones that help you with immunity. And so keep that in mind. But if we're talking only about unvaccinated individuals, and we look at immunocompetent versus immunocompromised, the immunocompromised patients are going to do poorly compared to, or are going to do worse, I should say, compared to immunocompetent patients. When we're looking at vaccinated population, the same applies. So comparing a vaccinated immunocompetent patient to a vaccinated immunocompromised patients, they still do worse than their immunocompetent counterparts. If we grab a sample of immunocompromised patients, and I'm going to compare again only CLL patients to each other, and we look at patients that are vaccinated versus unvaccinated, there's not a huge difference. And that has to do with the fact that a lot of our CLL patients don't respond to vaccine very well. And that's fairly well documented in studies.
And I would add to that these, when you're looking at vaccinations, you're looking at people who've had 1 shot and people who've had 6 shots. You're looking across generally those studies to get the numbers. But there is increasing evidence that the more boosters you get beyond, first, the CLL patients are supposed to have, at least at the beginning, their series wasn't 2 shots, but 3 shots. Everything's kind of changed now with all the new vaccines. It's a little hard to follow. But the more shots you get, the better protected you are, at least in terms of antibodies. And maybe there may be some clinical benefit for the people who are up to date with shots. Would you agree with that, staying very current and making sure you're up to date?
Absolutely. Absolutely. Not only that, I mean, we do see, if we're comparing the same vaccine, the more doses you get, the higher the rates of responses. And that was part of the reason why even in immunocompetent patients, not even immunocompromised, but immunocompetent patients, I have gotten 4 doses of the vaccine, or 5 actually. And I am immunocompetent, but just not only the fact that you respond better with more vaccines, but also the fact that each one of the vaccines that have come out include the newest variants. And so the updated vaccine includes the most current variants that we have. And so it's a different composition to the vaccine. So think about the COVID vaccine like you would for the flu shots, right? Every year we look at the flu strains that are floating around, and we make that vaccines every year based off on that. And sort of the same situation is happening with the COVID vaccine, whereby we look at the more recent variants and build the vaccines that way. And so the updated, most recent version of vaccine is very different from the very first one that came out. And so it's almost like a booster for people that have responded to vaccines to protect them against the most recent variants of COVID-19.
And the most recent vaccine is a monovalent. So if your last vaccination was a bivalent, you're behind. You should have gotten a monovalent vaccine.
Correct.
We didn't hear much about the Johnson & Johnson vaccine. Can you comment on that and what the status is with that?
Yes, so that's phased out. We don't use that one anymore. So only those three that I had mentioned are the ones. And I did catch a little thing on the recording for the Novavax vaccine is 2 doses separated by 3 weeks. I think I said separated by a week, but that's not true. It's 3 weeks.
Okay. And are there any new vaccines that you're excited about or that are coming out?
Not quite yet. Not quite yet. I'm actually interested to see if we're going to study the RSV vaccine in immunocompromised population, because we know how different the responses can be.
There's a study going on near where I live at City of Hope with the GeoVax vaccine, which is an actually attenuated live vaccine, which we're not supposed to take as CLL patients, but its safety has been studied in patients post-transplant who are also profoundly immunocompromised and seems to be safe. And the early data is encouraging, but we'll wait to see what those studies have shown. That would certainly be eye-opening. Tell us a little about the new Prevnar. There's a new Prevnar vaccine. You mentioned that Prevnar 20. If you've had the Prevnar 13 in the past, should you get, or the Prevnar 7 in the distant past, should you get the Prevnar 20?
Yes, so ideally, yes. The Prevnar 20, the main difference is that includes, as the name says, 20 different serotypes of the pneumococcal vaccine. But when it comes down to looking at the last vaccines you've had, we really have to be careful to see how many vaccines you've had in the past to be able to comment on the ones that you should be getting. But yes, the updated, the Prevnar 20 is the one that we're recommending now. And in fact, if you've never gotten a vaccine before, that would be the one that we would offer, followed by the more commonly known pneumovax or pneumococcal shot is what we call it a year later. However, certain patient populations, immunocompromised, may benefit from getting that vaccine a little sooner. So if you've gotten it before, if you've gotten pneumovax before, you would be due for getting a Prevnar 20. There are different types of vaccines. The pneumovax vaccine is different from the Prevnar vaccine, so it stimulates your immune system a little differently. So based off on the amount of vaccines that you've had in the past, you should probably get the updated and see if you qualify to get the updated one or the more recent one.
My understanding too is the Prevnar 20 is at least in immunocompetent patients gets a stronger response.
Correct.
And you can even go further. You can test your antibodies before to the various strains of pneumococcus, and immunologists can do this with you, and then test after to see how your response. Of course, there isn't some magic number that if your if you go up 20-fold, you're protected, and if you go up 6-fold, you're not protected. There's no magic number. Let me use that as a way to switch to talking about testing for COVID. First question, which we always worry about, are there certain strains of COVID that don't show up on the home tests? Are the COVID virus is constantly mutating? Are there ones that won't show up that I could have COVID but test negative over and over again?
So no, so especially not the home antigen, you could potentially test negative depending on how you caught the samples and the timing of testing and many other factors. But the one that we do, which is what we call PCR tests, which is looking for the genetic material of virus, those tests are highly, highly sensitive. So it's highly unlikely that if you test negative repeatedly that you have COVID. They check a particular a particular well-preserved area of the virus. And so this, as I said, they're very, very sensitive testing. So if you repeatedly tested negative for COVID-19, but you do have symptoms, you should probably be checking other viruses as well. So as I mentioned before, all these viruses have very similar presentation in terms of symptoms. And so if you test negative for one, you have to make sure you test for the others. And generally, we'll do a combination of influenza with RSV and COVID as a testing, because those are the ones that we can treat right away.
But the home test, if you have negative home tests and you think it's COVID, you've been exposed to COVID, would you recommend that you try to get a PCR test at that point? If you're say, hey, I'm at risk for COVID, but I've tested negative with the antigen test, I have symptoms that are consistent with COVID, would you recommend trying to get the PCR test?
Absolutely, absolutely. And like I said, our healthcare personnel is highly trained on how to do those swabs to make sure that we maximize the chances of picking up any viruses that might be there. And if we're bringing you in for testing, we would not only test COVID, but we would typically test other viruses as well. So that's very important to keep in mind too. So always start with the home test. If that's negative, you still have symptoms, we would move on to the next step, which would be checking PCRs for not only COVID, but also flu, RSV, and sometimes others too.
And there was some talk, and I've seen that, I haven't seen this recently, about maybe going at the throat and not just the nose. Is that not thought of anymore? Is it just a nasal swab now when you're looking?
That's correct. We used to do the saliva test for COVID-19. It's just a quicker way and it's easier for people to do it. But we've kind of shied away from doing that and just go straight to the nasal swab.
There's a couple tests that are available to patients that are considerably more expensive, where it's kind of a lab that's mailed to you. There was one, Lucira, which I think is no longer available for COVID, but has a COVID flu, and it's supposed to be as accurate as PCR. It uses a different method. And then there's Q Health. And at the end of this, we'll give you a link to a discount for the Q Health test. Do you know anything about those? Can you comment on those particular tests and if you recommend those for your patients?
So I have no personal experience with either one of those tests, and I would still be concerned about the way the samples are obtained. And so if you start with that, that's totally fine. If those tests are positive, then we would definitely treat you. But if they're negative, I would still call your provider to get yourself tested with a PCR test at a healthcare facility.
Someone asked about checking antibody levels, and you can do that yourself at Quest Lab. Now you can check your antibody levels. What's your feeling about patients checking their antibody levels? If that's part of what you do, how helpful that is?
Got it. So I'll start by saying that the immune system is highly complex. So checking a single test doesn't tell me the whole story about how you'll be protected for different kinds of infections. At the very beginning, we were checking antibody tests to see who would respond to vaccine or not, but it's not that simple. So, and we don't even know what the correct titer is. So CLL patients actually, when they get vaccinated, not only do they have a lower chance of response to vaccine when we check antibodies, but the other part of it is that the titers are actually much, much lower, meaning the actual amount of antibodies that you're making are lower compared to other patient populations. Moreover, there are different kinds of antibodies that we check for. One particular one, which is called neutralizing antibodies, rarely produced by patients with CLL, and that's actually the one that helps, for the most part, protect against the virus. We also know that a lot of our CLL patients do have antibodies against different coronaviruses, which is within the same group as COVID, which should provide some cross protection, but it doesn't really. And we're starting to learn about this phenomenon too. And so you could check an antibody response, provided that you're not getting supplementation. I had mentioned intravenous immunoglobulins and others, provided that you're not taking any of them, because the test will pick up those antibodies as well. So you won't know whether you responded to vaccine or that's from replacement of your antibodies. But that single antibody test although it helps me to say, okay, you may have some response to vaccine, it doesn't help me to tell you, oh, you're absolutely protected. There's more to that story. So your antibody tests are really looking at a particular part of your immune system. There's another part of your immune system that also helps you protect against COVID, which they're called T cell responses. And so we don't know how to interpret that antibody response very well. I think where it's really helpful is if you got vaccinated and the antibody is actually negative, then we know you're not protected at all. If your antibody titer is high, we could tell you, yes, you responded to vaccine. Whether you're protected or not against COVID is a whole different story.
Let's stay on that just for a second. At least in the immunocompetent, it seems the data, to be honest, is somewhat disappointing in terms of protection against COVID post-vaccines. Not talking about protection against hospitalization and ICU and death. That's impressive and is a good reason to get the vaccine if you're immunocompetent or immunocompromised. I think that there's arguments to be made. But for protecting against the infection, it seems to fade quite quickly. And there was floated, at least the CDC talked about when they came out with the latest, is talk to your doc about how often you should get the COVID vaccine if you're immunocompromised. And people talked about every 2 months. That was an option that's out there. Is that something that you're talking to your immunocompromised patients about, getting a COVID shot 6 times a year?
No, not really. No. So there was a lot of confusion about that recommendation. And I think it stems from the fact that we were assuming with that recommendation, the CDC was assuming no prior vaccination. So meaning, for example, those patients that get a bone marrow transplant, for example, that we give them very strong chemotherapy and essentially eliminate all their previous vaccine responses. So in that setting, we would probably do a dose every other month. So that was a previous somewhat confusing recommendation that came out, but that's not happening any longer. And you're absolutely correct. The vaccine is fantastic at preventing severe forms of COVID. It does not prevent against infection. So you can still get infected. You may still have symptoms, but we really want to make sure that the severity and the mortality are reduced with the vaccines.
Can you talk about the T cell function and the cellular immunity in CLL patients? I've seen some data that suggests that people can get, LLS did a study which showed that there was some T cell response, even in people who didn't have antibody response, but it too is limited, correct?
Correct. And that has to do with the fact that, again, just like with antibody testing, everybody checks a different sort of T cell response. So it's very hard to make a uniform decision in terms of how we test for cellular immunity. Patients with CLL tend to have better T cell responses than B cell responses because of the targeted treatment that we give them. However, there's also another part of your immune system, which is called adaptive immunity, which is essentially how your body learns older infections and help you protect against them. That part of the response in CLL patients is also not perfect, and it's probably also non-functional. And so that's also another reason why, even though you may have T cell response, there's a lot of interactions between your T and your B cells to get you protected against different infections. And so even if you have T cell responses, but you don't have B cell response, it's almost like a part of your immune system fails to communicate with the other, so you still can't protect yourself against COVID-19.
Yeah, we also, our innate immune system is impaired too. I mean, all parts of the part
all
that
parts.
respond.
That's right.
Respond.
That's right.
A couple alternative therapies. There's a nasal spray, Enovid, from Israel. I can't imagine you haven't had patients talk to you about this. I wonder if you have any thoughts on that and why we're, so yeah, talk about that. And then I'm going to ask you about a couple other things that were very popular a few years back. I think you know what's coming, but talk about the nasal sprays and if you have any thoughts on those.
Yeah, so first of all, that's not an FDA-approved
Right.
drug in the US. So we do not use it. It is the nitric oxide based spray that you essentially squirt, and it claims that it kills viruses 99% of the time. However, how frequently you can use that nasal spray, we don't know. Is it safe? We also don't know the answer to that. So I usually shy away from recommending any non-FDA approved nasal sprays. There was another nasal spray, I'm blanking on the name right now, but it was a zinc oxide base. It had the same idea of preventing virus from binding to your respiratory cells up in your nose. But again, vaccines are probably a better protection against the viruses. And hopefully when we have monoclonal antibodies available again, that's a perfect complement to vaccines, especially in people that we know are not going to respond to vaccine very well.
There's a iodine-based, a proviodine-based spray also available, which you can get over the counter, non-prescription, mail order and stuff. So hydroxychloroquine and ivermectin, what's the latest on those? There's still people that are interested in those, or is it a conspiracy, the medical community shut this down, or gives, because there was some data that came out that looked promising at the beginning, for both therapies.
Right. So I think we quickly learned, and I have personally used hydroxychloroquine at the very beginning of the pandemic, but I think we quickly learned not only was it not helping our patients, but it was also harming them and has a lot of different side effects, specifically cardiac toxicities, where we would put patients at higher risk of getting very, very sick. And it was also not effective. Moreover, all the other antivirals that I've mentioned are highly effective, particularly Paxlovid and remdesivir. And so we don't use that anymore. There have been an incredible amount of trials that have shown that ivermectin has no activity against COVID-19. So we don't use it here. And in fact, ivermectin was studied for other indications such as HIV cure. It was never proven to be effective. And so another one that has was sort of deemed not to be effective at all in several well-conducted trials more recently.
Tell us, just switching here, about when someone, someone says somebody is exposed to COVID, they're not testing positive. Let's say a grandchild or a child is exposed to COVID, they're not testing positive. You see them the day after they're exposed. Could you get COVID from that person who, it's sort of like 2 degrees of separation. That person doesn't have COVID, may not get COVID, but could get COVID. Could they be contagious at that point? Let's say if they coming down with COVID. When do you become contagious with COVID? When's that high risk period? Because we know there's an asymptomatic period for days before the person starts coughing or sneezing or gets the sore throat.
Right. So you can be contagious 3 to 5 days, even before you have symptoms. That's absolutely correct. You can catch the virus pretty quickly. For the most part, once you test positive with or without symptoms, it can be contagious. I mentioned that little scenario of people that can test positive for a long time, and we see that pretty frequently in immunocompromised patients. We know that patients that are immunocompromised can be persistently positive for about 3 weeks, even longer. So they can be contagious for that long. So 3 to 5 days before having symptoms, but many weeks after as well for immunocompromised patients.
Is it true for the immunocompromised that if you test negative, you're no longer contagious? Or is that true for anyone? I mean, that seems to be the sort of wisdom you may talk to us about. When is it safe, if you've come down with COVID or your family members come down for COVID, that you can have them over for dinner or whatnot?
Right. So the CDC recommendations stand true for what normal quarantine is, and for immunocompromised patients is still 20 days. I don't think we know enough about, so there's 2 different tests that or 3 actually, that we go to see if patients are still contagious. And so one of them used to be, and you may have heard about, the cycle threshold. It was never supported by any scientific societies, and in fact, we don't use it anymore, but it was a quick way for us to know, or for us to have an idea how much virus was still floating. And it was a number that was attached to the PCR test. That test was never validated, and most areas of the US don't use it anymore. The other way to know if you're still contagious would be to obtain something called a viral load. So there are some labs in the US that after doing the PCR testing, if you're positive, they actually measure the amount of virus that you have. It's not a standardized test, so each test will have a different value attached to it that we don't know enough about yet to really comment on what the threshold would be above and below the specific number that they give to see if you're still contagious or not. But we know that if you have a large amount of virus, you're probably still contagious. And then the one that we're using now is the home antigen test. So it seems that if you're still positive via home antigen test, it seems that the virus is still viable and you're still contagious. We've seen a number of occasions that when patients are testing negative via the home antigen test and they still test positive via the PCR test, we see that those patients, when we used to have the cycle threshold value, they were pretty close to become negative. So I think the home antigen test is a good surrogate of whether you're contagious or not still. But again, that's not been validated. We still have a long way to study those things.
A lot of us were really excited when we had passive immunity through Evusheld, and then there was other options with Regeneron and other things like that. We know that there's trials that are ongoing, trials that have closed. Do you have any inside information that you can share with us about when there might be another monoclonal antibody to provide us some extra protection, where that is at? Any open trials if patients are interested?
Yeah. So the AstraZeneca trial, we were actually one of the sites that were enrolling, and that finished enrollment by the end of October. I don't know when that's going to become available because we don't have the results yet. And there was some rumor that it may not have been very effective for the most recent variants. However, they have not come out to say one way or the other. So we're still waiting for those results to come out. Regeneron also has a new product that they developed slightly different from the ones before in a way that it targets a different area of the virus compared to the other monoclonals. It also lasts for a very long time. That study should probably begin enrollment by January, so it would still be under clinical trial, but definitely something to look forward to. I don't know where the third company is with their development and trial. That would be Invivyd. But I do know that Regeneron should be enrolling sometime in January.
Yeah, the Invivyd trial is now closed. They had an arm that was for immunocompromised. And what was nice about that arm is that there was no randomization. Everyone got the active antibody. And they had 300 patients, and that's closed now. So
which was not the case for AstraZeneca, and it's not the case for Regeneron. They're both placebo controlled.
Right. So only the immunocompromised cohort of this larger trial was not randomized. And I have to say, CLL Society pushed pretty hard to have that as an option for us to see how we would do. Well, and I understand I understand the AstraZeneca, we may get results in the first quarter of next year. That's what I'm hearing. Mm-hmm. And the Invivyd may not be much past that. Maybe in the first half of the year is what they're hoping for. Let's talk about IVIG for a second. First, my understanding is, and tell me if this is correct, you could test positive that you had COVID because it contains the nucleocapsid antibodies too. So even though you've not, which is the test to say I've had the infection, not just the vaccine. So you can get a false positive test from IVIG is that you've had COVID. Is that correct?
You could. You definitely could. I mean, keep in mind that IVIG now is full antibodies from people that have had the infection, have been vaccinated. So yes, you could definitely test false positive. And the IVIG has now very high titers of COVID antibodies. And so we think it's probably quite similar to essentially giving convalescent plasma at this point, which is the other version of antibodies, but it's only COVID specific antibodies.
So let me ask about that, because IVIG is a pooled blood product from what I understand, thousands of patients, but aren't the antibodies I'm getting a year old? Doesn't it take a long time for that IVIG product to get from the patients into the immune compromised patient?
That is absolutely correct. So it's a year old, so it won't have antibodies from the most recent vaccines. Hoping that it'll have at least a bivalent one and include that, but it'll have antibodies against infection. So keep in mind that they're still protective, even though they may not be perfect against infections, to the point that some people think that you may get away with IVIG only without the COVID vaccine. We would still recommend that you get the COVID vaccine for whatever benefit you may draw from it. Keep in mind, that new variants come out, so the vaccines are updated. And so there's no harm in getting the COVID vaccine unless you had very severe symptoms from one of the vaccines. And that's a conversation with your own doctor. But yes, you're absolutely correct. They reflect antibodies and variants from a year ago.
Let's spend a little time on the timing of the COVID vaccines with other treatments. There was a question about holding ibrutinib. And, I can take this one if you want. There's some papers out of ASH, and there's been some earlier data out of the NIH suggesting ibrutinib, and I would assume it would be acalabrutinib and zanubrutinib too, the BTK inhibitors, that if you stop those, and it varies depending on the numbers, but, for a few days before and maybe a week or 10 days after, depending on the trial design, that people have a better immune response. The decision to hold the medicine would depend on where you're at in your therapy. Generally, people whose disease is well controlled, have been on the medicine for a year or more, can stop it for a couple of weeks without any adverse events. If you're early in the disease, you can get a rapid flare of the disease, and it may not be a great idea to stop it. Do you have a sense of what people should do about their BTK inhibitors and getting vaccinated? And I guess it wouldn't apply just to COVID, it would apply to any vaccine.
Right. First of all, I should say never ever stop any of your vaccines without talking to your providers first. And I think, right, any medications. And so the ideally, if you're asking an infectious diseases doctor, ideally we would want to hold your chemotherapy if we can, or immunotherapy, or whatever it is, if we can, for a few weeks before and a few weeks later. And we've seen that, and we've studied extensively in solid organ transplant patients, where we would hold certain medications that we know are going to affect vaccine responses higher than others. And so that would be ideal. But then again, there has to be a conversation between patient, cancer doc, and infectious diseases doctor. So ideally, if you can't, that would be great. If we can't, still get the vaccine and see if you draw any benefits from it. The one that we know that is just not going to be any benefit are what we call the anti-CD20 inhibitors, so rituximab and others. We know that we need to.
Or Gazyva would be the one that's
obinutuzumab too, exactly. Yeah. So we definitely know that those will not allow you to respond to vaccine. And so we've recommended waiting at least 9 months, ideally a year after any of those doses, to actually draw any benefits from the COVID-19 vaccine.
And we encourage everyone that if you're going to be starting on therapy, especially if it's one of these monoclonal antibodies, rituximab or obinutuzumab, that you get vaccinated before you start. Get all your vaccines, get those in place. What about the timing of, there was all kinds of talk before about the timing of Evusheld and vaccinations and which should come first or the same time. What about IVIG? Are there concerns about vaccinations and the timing of IVIG? Could the IVIG interfere with the efficacy of an already diminished response to the vaccine?
It doesn't seem that it does. And it's funny because we had just the same conversation with one of our adult immunology, well, he's really pediatrics, but one of our immunologists here at Hopkins, and we posed the same question to him. Is it okay, and what the timing should be? And his response is that we don't know what the right timing would be. If anybody wants to take, and also some people take the IVIG every week, every other week, every 4 weeks. It really depends on how your antibodies measure after each one of those doses. And so we don't know for sure that it may cause decreased vaccine responses. It could, we just don't have enough information to know that for sure. And so his recommendation was to space them out, perhaps a couple of weeks, get the vaccines, as long as you're not having very overt side effects from the vaccination, but still get the vaccines.
Yeah. Let's discuss something that maybe we'll spend a couple minutes on, and we can get a little philosophical about this. And I'm sure you deal with this and I deal with this, is balancing the risks versus the social isolation, in how you approach this. There's a ton of questions about getting together for the holidays, going on a cruise, traveling somewhere. How are you advising your immunocompromised, your CLL patients about this and what they can do in this regard, how to balance that? Because there's also tremendous social isolation, depression over this. And studies after studies have shown that, people live longer who are connected, so you do better
Exactly.
if you're connected.
Yeah.
There's studies that show people with lymphoma who have a significant other in their life live longer than people who don't, so how do you, I'm sure this is part of your practice every day.
Yeah. I had a very long conversation, about an hour, with one of my patients about this very question. So, and just to put it into perspective, she's very young, she's very active, or she was very active before COVID-19, and she did a fantastic job by getting vaccinated. And, she stayed at home. She would mask whenever she went out. But this year, she called me to say, hey, doc, I want to talk to you because I think this is really affecting my life. And so she was telling me how her and her partner were becoming very isolated from the group of friends. She was becoming increasingly depressed because she wanted to be with her family, but at the same time, she was really worried about getting COVID. My take on it, I think we had a very good conversation. First of all, knowing signs and symptoms, right? And so if you know what COVID looks like, it'll be easier for you to be on alert to get tested. And I think that was one of the most important things that I told her. This doesn't apply only to COVID, right? Flu can be as severe, RSV can be as severe. All those viral infections can really take a toll on patients that are immunocompromised. So first of all, learn what the symptoms are and be on the lookout for it. If you feel differently, if you have fever, chills, any kind of symptoms, the number one and most important thing is to get tested right away. If you get tested early when you start having symptoms and you know what you're facing, you should then contact your provider immediately so that we can treat you. I think that's the part of it that's going to, have the higher rates of success in terms of, putting you at risk for very severe infections. Because we know no matter how many vaccines you get, the more COVID vaccines, the better the response is. But you may still have no response to influenza, to RSV, to COVID. And as we said before, all those IVIGs that we get are from a year ago. So they're not going to include the more recent strains, both from flu and COVID too. And so that's one part of the equation. So getting tested and treated early. The second part that we talked about was to be smart about it. You're going to be around a lot of patients or a lot of people that you don't know their vaccination status, or they may not know about your own disease, right? Because those people that are closer to you that know about your condition will be very wary about coming to you when they're having symptoms. So the other part of the equation is to teach those around you about your condition if you're willing to discuss that. And also get everybody around you vaccinated. The more up to date they are with vaccination, the lower the chances that they'll transmit that infection to you. Another part of the equation is to ask people that you're going to be meeting with, if they have any symptoms, they should let you know. And if they do, then perhaps have them not come to you, or try not to go to that meeting yourself if anybody in that meeting is having symptoms or had recent infections. It's always a good idea not to be in large crowds, and this applied even before COVID. We would teach our patients during the winter season not to be around a lot of people. Again, there are many different viruses. It's not only about COVID, and COVID is going to become part of our, yearly virus panel. And so trying to stay away from large crowds still applies. I think wearing masks at this point has become almost like a normal thing for people to do, almost like a choice. So it used to be that if you were wearing masks, people would know that you're sick for some reason. But right now, if you go, for example, to, I'm going to say Costco or any other major grocery store, there are people that are wearing masks. So that's another option for you too. So it's hard to be isolated. It's been over 3 years. Just like you said, being around family and friends increases your quality of life. And so I think it's important to share with loved ones, but at the same time, be smart about it.
So I look at this as balancing the risk-benefit ratio. And I think that there are things that are incredibly beneficial. Going to a child's wedding or going to a birthday party for a grandchild or something. These are things that have a risk, but they're the benefits versus maybe, going to a concert, which might have a really high risk if it's an indoor concert, and maybe that's not worth the risk. I mean, all of us have our different lines that we draw. So those are the kinds of things that I look at. It is a trip that I've always wanted to do. Then I think N95 masks are incredibly protective. And I think if you're very careful about it, I'll tell you where I personally draw the line. I don't eat indoors at restaurants. I will eat al fresco outdoors, even if it's cold. I eat outdoors. And if I can't do that, I have the food delivered to my hotel room if I'm traveling. That's what I do. That's where I draw a line. I don't go to big concerts. I don't go to hockey games, though I'm from Canada and I might lose my citizenship if I don't attend a hockey game at least once every year. So there's risks that I'm willing to take and not willing to take. But we have people over. I'm living in Southern California. We meet in the backyard. If we're indoors, we wear masks. That's what I do, and to try to prevent social isolation. I try to get my grandkids, they're old enough where they can wear masks, not so good at wearing masks, but they can wear masks. So that's kind of what I do. Is there, what about testing people before they come over? Do you think that that's helpful to do a COVID test to say, before you walk into my living room or you join us for Christmas dinner, we're going to test everybody? Do you think that's a good idea?
Yeah, I get this question also pretty often. It depends on your level of comfort with the people that you're meeting, right? Because you're asking a big ask, right? Putting a swab all the way down. At the same time, it's a matter of how you collect that sample too. So if the antigen test is negative, it's possible that they don't have any symptoms, but if they grab, the little cotton tip and they just kind of pushed it around very quickly and didn't get a very good sample, it could be negative, but that doesn't mean that they don't have it. So you could ask them if you're comfortable doing so. Is not necessary. I think more importantly is to know if they were sick at the time that they visited you, or if they became sick a few days later, so that you can be on the watch for those symptoms.
And what about ventilation? There's like the CO2 monitors, and ventilation seems to be a big issue now, a bigger thought. Any comments on that in terms of how important that is? I admit it's one of the things I consider when I'm going to something. I think about how big is the room, how many people are in it, how well ventilated it is. Is that something that you advise your immunocompromised patients to consider?
So the bigger the room, the fewer the people, the better you'll be, for sure. If you have open windows and air is flowing, absolutely great. But if you're in the middle of Minnesota, maybe where it's super cold, it's going to be hard to do that. So the bigger the rooms, the better ventilation is always best. However, if the person sitting right next to you has COVID but not exhibiting any symptoms, regardless of how big the room is, you may get COVID. So it's that part too, where asymptomatic patients can still transmit regardless of how big the room is, if they're close enough to you. That's where that recommendation of social distancing came from, even if you were outside.
And let's talk about that. Is that still the 6 feet recommendation for
That
social?
is still, yeah, for social distancing, correct.
All
If
right.
that's something that you would practice, that would be the recommendation.
A couple vaccine things I want to make clear on, and I'll just run through these. If you get vaccinated against COVID, that protects you against COVID. It does not protect you against RSV or flu. You have, those are specific vaccines. If you get the pneumonia vaccine, it protects you against the bacterial cause of pneumonia, Streptococcus pneumoniae or pneumococcus, it used to be called. It doesn't protect you against the other. If they test you for COVID, you're tested for COVID. There are tests that test for COVID, flu, and everything at once, but that's a specific test. But the test for COVID only tests for COVID. You could have flu, but not have COVID. You could have flu and COVID too. In theory, you can have both. So to be clear on that. A couple other things that came up. The pneumonia vaccine, is that one and done if you've had the Prevnar 20 and you've caught up, or is that a vaccine that you're going to have to get again, like we have to get COVID and flu vaccines?
It's not a yearly vaccine, that's for sure. So the current recommendation is to get the Prevnar 20, and then a year later, you get the Pneumovax. They're very different vaccines in terms of their composition, and they cover different serotypes too. But it's not something that you would get every single year. And many of you may have had several other vaccines. So there were not Prevnar, but Prevnar 13, Prevnar 20, and there were 2 others that had 10 and 13 serotypes of pneumococcal too. So it really depends on how many vaccines you've had in the past, but it's not a yearly thing like it is for flu and COVID.
And we don't know yet whether we'll be recommending boosters for those down the line. At this point, there is no recommendation. It's kind of one and that's it. And then, wait. Can you comment, though it's not a respiratory, on the Shingrix vaccine and the importance of that for the CLL community?
Oh, highly important. So, and again, just like with other vaccines, and this is not the live attenuated vaccine anymore. So this is something that you can get anytime. But also keeping in mind, although it's very good at preventing shingles, it's also very good at preventing the pain that you get after shingle, which we call post-herpetic neuralgia. So it's very important to get it too. A lot of times, though, patients that have CLL, even if they get the vaccine, they're still getting immunotherapy or chemotherapy. We would sometimes still consider giving them antiviral prophylaxis. So taking an antiviral pill to keep you from getting shingles. But that's actually something that you should also get. So that's another vaccine that even in people that are getting IVIG, the immunoglobulin supplementation, that's another vaccine that we recommend getting. Yeah.
And for me, at least, it's a series of 2 shots, 6 months apart, and the insurance will cover that for the immunocompromised. And now that it's no longer a live vaccine, it's really helpful. And you don't want shingles. You don't want herpes zoster infection.
Not at all. Not at all.
So this may get you a little out of your comfort zone, and I'm happy to respond to this. How does the COVID vaccine or other vaccines affect the CLL, SLL itself? It's an immune stimulant, and we have a cancer of the immune system. Is there any negative effects on our cancer from the vaccine? We've talked about the positives, but are there any negatives other than the misery some people go through for 2 or 3 days after the shot?
Yeah. So I don't know any scientific data that would say that COVID vaccine is harmful to treatment, although it does stimulate your immune system. We have seen a fair amount of cases where they presented with a new diagnosis of a cancer in COVID-19. Whether that is because they had cancer for a little bit, now they're immunocompromised, and that led them to have severe COVID, we don't know.
Yeah, and I've seen people get their lymph nodes around where they've gotten the vaccination swell up, and they can take a while, and people's absolute lymphocyte count can go up, and it does stimulate the immune system. And there are certainly anecdotes of people whose CLL has accelerated afterwards, and usually it slows down again. But anytime you're fooling with the immune system, there's some risks associated with, but generally I think the benefits strongly outweigh the risks in these circumstances. There are Mycoplasma avium. Somebody asked about that. Can you comment on that as a risk for, is that a particular bacterial risk for CLL patients?
Mycobacterium avian?
Mycobacterium avium. I'm sorry. Yeah.
Oh, yeah, absolutely. Yeah. So that's a very special kind of bacteria, very slow growing. It can cause disseminated infections. We do not have a vaccine against that one. Treatment's actually pretty complex with 3 or more drugs for many years. Something that can affect any CLL patients is what we call an opportunistic infection, meaning that bacteria takes over and causes infections only in those who have an impaired immune system.
Yeah, so it would be one, and pneumocystis was another. Yeah, and sometimes the treatments can increase your risk of that, and there's drugs that you can take prophylactically to prevent that. One last question on immunization, and then we're going to close up. Are there times that we should get? I had a bone marrow transplant, and I had to get revaccinated, including childhood vaccinations. So that's pretty well understood, that science. Are there other times, like if I've gone through a treatment, I've had monoclonal antibodies, I've had a bispecific antibody, I've had CAR T therapy, that you say, now with CAR T therapy, people are starting to say get revaccinated. Is there a time that you should get all your vaccines again, or at least some of your, non-live vaccines again?
So we are doing that after CAR T cell too. Because when you get CAR T cell, what we call the preparation regimen is very, very similar to what you would get for bone marrow transplant. And that, again, wipes out all your prior vaccinations. So we are revaccinated CAR T cell patients. Outside of bone marrow transplant and CAR T cells, we don't really resume all childhood vaccinations again. So those are the 2 circumstances where we would recommend revaccinating.
Interesting. I wonder if we look for people with other lymphomas where they're treated with heavy chemoimmunotherapy, whether they should be revaccinated at the end of that time. Is that standard of practice now? Like somebody that's with Richter's transformation, let's say, gets EPOC or R-CHOP or something, would they get revaccinated after the lymphoma is treated? Okay.
Not with childhood vaccinations. Sometimes we'll revaccinate with COVID, flu, and others, but not childhood vaccinations.
Well, we're closing in, and there's 100+ questions. I would say if you send in your questions early, I think I got to everybody who sent in a question, and people did ask about travel and grandkids over, and I think we've covered that without specifically saying whether you're going to Alaska or Hawaii or whatnot, but I think it's the same. I will say I sit on an airplane, and I agree with you. I mean, I put an N95 mask on, and I don't take it off until I get into my hotel room. I mean, I don't eat or drink or do anything. And people asked about what kind of N95 mask, and the most important thing is that it well fits, whether it's duck-billed or whatever shape it is. I don't think that matters. Does it fit you well? Does it not leak? That's the important thing. And I just don't take it off. I try to sit in a window seat so I don't have all the people sitting by me. But that's about the only tip I have for flying on a plane. Any final thoughts you have, or anything that you want to share with the community? This has been incredibly helpful. I'm so grateful.
If you take anything out of today's discussion, I think early testing and treatment is the most beneficial part of this. We don't know that you respond to vaccine, but stay up to date with them. If we are lucky enough to have pre-exposure prophylaxis, what we talked about with monoclonal antibodies, I would really encourage you to do that as an added layer of protection, not as a replacement for vaccines. So early treatment, early testing, stay up to date with vaccines, and be smart and careful.
And I would add that while the vaccines provide very imperfect protection, they probably provide some protection. And while the mortality rate in CLL with COVID infections and with pneumonia and RSV is higher than the general community, unacceptably high, it is way, way better. And you can pull statistics that suggest that it's minimal or that it's significant, but all of the statistics are way better than it was a couple of years ago. And I think one, it's because we have immunity. Two, because we have great treatments. Three, we're better at managing it outside of those treatments. And four, I think it's the nature of the virus itself, that the virus is more of an upper respiratory infection, at least for a lot of people. It causes the damage to the lungs, and we know better how to handle that and prevent that. So it's still a very serious illness for us, but the mortality rate and the ICU admission rate and the rates of being on respirators is way down. How much down is controversial. You know, I've seen numbers anywhere from 1% to 10% mortality rate still going on, which is a huge difference, but it's not the 30% that it was consistently at the beginning. I'm very grateful for this. Once again, we want to thank our generous donors in AbbVie and AstraZeneca for making this possible through their support. Thank you all for joining us today. Big thanks for Dr. Dioverti and Robin Brumble, nurse, RN, for their presentations and thoughtful, the very, I think, engaging and thoughtful responses to the questions. Please, please, please complete your event survey and provide us with your feedback so we know what we did well and what we didn't do well. This event was recorded and will be available with the slides at the end. We'll also send some information and some links for some of the testing and stuff like that. Plus, if you're interested in this Q Health, we'll make sure that you have a discount code for that. If your question wasn't answered, and I know that it wasn't answered because I lost count of how many questions, there was 130, 140 questions, send it to asktheexpert@cllsociety.org. And a number of you sent very good questions on CLL itself, and I tried to respond to those, but this really wasn't the forum to deal with that. But again, I ask you to ask the experts. If you send it in, I will try to respond. If you have a CLL specific questions, we really welcome those, and we'll try to get to those. But for obvious reasons, we didn't deal with those live today. Please join us for our next event, which will come early in 2024, which will be a review from ASH 2023. The CLL Society is excited to be returning to ASH for at least the dozenth time, and we'll be presenting the latest research from there. Please remember the CLL Society is invested in your long life, and you can invest in the long life of the CLL Society by supporting our work. This is our end of the year, and approximately half of the support that we get from donors comes in this last month. And if you're in a situation where you can support us and help us with our mission to educate you and make sure that everyone gets their best possible care for CLL, we'd be greatly appreciated if you can make a tax-deductible charitable donation. And I'll close, as I always close, with stay strong. We are all in this together. Thank you for your attention. Please fill out the review. We look forward to seeing you again post-ASH.